warahmatullahi wabarakatuh, and very good morning to everybody. My name is Hafiz. I'm one of the nephrologists in UMMC. So thank you for coming for today. So today is a special day for us nephrologists because this week, or particularly tomorrow, will be the annual celebration of World Kidney Day. So this year's theme is like behind me there. So living well with kidney disease. So for this particular day, we thank Faculty of Medicine Breakfast at FOM for giving us the opportunity to discuss, or we have panels of experts that we will discuss about, how to live well when we have kidney disease. So together with me today, we have Associate Professor Dr. Maisarah Jalalonmuhaili. She's a nephrologist with a special interest in kidney transplant. We also have Dr. Sheriza Izwa Zainuddin, who is a palliative care consultant in UMMC as well, and she has great interest with end-stage kidney disease. And together with us, we have a patient, Mr. Kaldip Singh, and he had kidney transplant for many years ago, which he shall say later on. So the way we're going to do this is basically like a forum style. I'm the host, and then I'll throw out question to Dr. Sheriza, Dr. Maisarah, and Mr. Caldip. And you can join us by asking question in the Q&A session as well. So the objective of this talk today is just to show you how people with kidney disease, despite either they have transplant or dialysis or even palliative care, they would still have the opportunity to live a decent life. Okay, so we're going to start with Dr. Maisarah first, okay, since she's here. So Dr. Maisarah, so we'll start off with the CKD, things like that. So often we receive a referral letter, because with all this eGFR and creatinine, for example, I'll give you a scenario, 70-year-old did a blood checkup and then suddenly saw that he has stage 3 CKD. Become afraid, when people associate CKD will be dialysis and everything. So what is your thought about it? So you can start with, what is CKD and try to answer the question.
Okay, Assalamualaikum and good morning. Thank you, Associate Professor Dr. Wan Hafiz, and thank you for inviting me for this platform in conjunction with WKD UMNC 2020. Yeah, I about to share my slide at the moment. Okay, so basically when we have referral of chronic kidney disease, they always come to our clinic with deteriorations of kidney function. So in simple terms, CKD is defined as when you have a deterioration of kidney function, of which we assess by eGFR, but more precisely based on the KDIGO guidelines, CKD is defined when you have as abnormalities of kidney structure or function presence for more than 3 months in the context of CKD, because as you all know, we have other kidney damages like acute kidney injury. In regards to the stages, there are 5 stages altogether, but more significantly when the patient presented to you when their eGFR less than 60, which is we classify as stage 3, when the eGFR between stage 3A 40 to 59, stage 3B 30 to 54, and so on, stage 4 and stage 5. Well, we are not just relying on one single value when they are presenting to us, because more importantly, what happened for the past 3 months. If we do have the baseline for the last 3 months, of which the baseline is about similar or slight deteriorations, yes, perhaps this kidney has been damaged for those for that kind of durations period. And as you can see on your left hand side, which is a normal kidney when you biopsy it, but in the context of chronic kidney disease, when you biopsy, is a lot of fibrous tissue or scarring. Apart from that, as mentioned in the guideline, of which there is not just the EGFR matters, we do see the urine abnormality as well. The urine is very important, I believe, for all nephrologists, of which in the urine we need to see whether there is a protein leaking, whether there is blood in the urine, and of course, imaging like ultrasound of the kidney able to help us give us some input to determine whether this problem has been there for a long period of time or is the acute onset. So more importantly is to differentiate between whether there is acute injury or chronic kidney injury. Yes, Dr. Hafiz did mention in regards to the dialysis, it's not everyone presented to us straight away need dialysis. Yes, of course they are worried because when the doctor say that they are CKD stage 3, they are kind of straight away made an appointment to see a nephrologist because of the worry of needing dialysis. Like I mentioned earlier on, stage 3A and stage 3B, even stage 4, we try our best to slow down the progression of the kidney disease with a certain kind of management depending on the etiology. And eventually, if the kidney problem and more importantly is basically to find the main reason why this patient has chronic kidney disease. As you all know, the main reason of chronic kidney disease in Malaysia is still diabetes. So taking history from the patient is very, very important. Diabetes conquer about more than 50% for our populations as a cause of chronic kidney disease, followed by hypertension. There are other causes of kidney disease like chronic glomerulonephritis, which is secondary to your like autoimmune problem, IgA nephropathy, systemic lupus erythematosus, as well as a patient's familial causes, polycystic kidney disease, or genitalial tract problems like renal calculi, obstructions, recurrent urinary tract infections. And let me touch a little bit in terms of how heavy load of our country having this problem, because we have many patients that end up with dialysis. This need to be highlighted because we need to try our best as a group from the beginning in terms of preventing the disease and subsequently to reduce the number of patients end up with dialysis. In Malaysia, based on the renal registry 2018, we have about 8,431 patients, new dialysis patients, and the prevalence of dialysis patients is about 44,000 up to date as compared to back 10 years ago, which is kind of double the number. Yep, Dr. Hafiz.
Yes, Dr. Maisarah, thank you very much for that. So just to go back to my question earlier on, so having a stage 3 does not equate needing dialysis soon. Is that correct?
Like I mentioned just now, stage 3 is basically when you have GFR less than 60. Yes, we are saying perhaps there is a significant damage to the kidney already, but it's not equal to dialysis because this is the time that the patient should come forward to get further consultation to the nephrologist or in fact your general practitioner doctor in order to retard first or foremost, and you need to find the cause of why your EGFR deteriorated, which is less than 60, and second, try your best to kind of slow down the progression of kidney function. As we all know, when we kind of aging, especially those more than 40 years old, our EGFR did drop because of our physiological process. Thus, this drop of GFR is not really significant. Perhaps it's about 1 mils per minute per year. But if you have other underlying problem or other underlying disease, it makes the EGFR drop faster. Especially in a fast drop in GFR, we are really concerned because we don't want them has this fast progression until it reaches stage 5. Back to your questions, dialysis. Usually dialysis equal to when you have EGFR less than 10. And in fact, based on the what people has been doing in terms of paper publication, we know that even though you are asymptomatic, usually in asymptomatic cases, basically you don't have any symptoms, there is no shortness of breath, there is no leg swellings. The rate of initiation of dialysis is when your EGFR less than 7 mils per minute, which is much lower than in stage 5.
Dr.
So,
Maisarah, I thought
yeah,
it's less than 15. I thought all the
yes,
medical students say it's less than 15.
yeah, it is less than 15. Less than 15 is very arbitrary number because it's stage 5. Stage 5 also is not equal to dialysis because during stage 5 we really need to prepare the patient. It's not stage 5, it's in fact stage 4. We need to counsel the patients, we need to prepare the patients in regards to the dialysis modality and prepare them what the best option for them, because we still can do transplant, especially when they are EGFR less than 15. A pre-emptive transplant is when the patient do not need dialysis as yet, but the EGFR has declined, especially when they reach less than 10. Less than 15, you are right, but majority of the patient has no symptoms even though their EGFR is less than 15 and more so less than 7. That's the reason why in asymptomatic patient, usually we do dialysis when it's reached less than 7 because we want to preserve residual urine output that they have. We don't want to start too early in terms of dialysis because we're going to lose the residual kidney functions, but we don't want to start it too late as well, because as a complication, if you like to start late dialysis and patient end up with a high rate of mortality. 15 is less than 20 is the best time for you to discuss with patient regarding mode of renal replacement therapy, but you will start dialysis whenever the patient has symptoms, or in asymptomatic cases, perhaps it's less than 7 rather than less than 15.
Okay. Can you quickly mention, you say a different modality when you reach end stage. What kind of a different modality that is available?
Yeah, when the patient GFR. Okay. Yeah, can you see my slide?
I can, yeah.
Okay. Okay. So this is just to easy illustrate to everyone is that we have different modalities. Basically, we start to counsel the patient when their EGFR deteriorated very fast and you think that you are unable to retard the progressions of the CKD. But believe us, all the nephrologists will try their best to retard the progression of kidney disease because they don't want the patients end up with end stage very fast. But eventually, the times will come. And we have in terms of type of renal replacement therapy, it can be either hemodialysis. Yes, we have home dialysis. Home dialysis is either peritoneal dialysis or home hemodialysis, but in Malaysia this home hemodialysis is hardly happening because of the cost and financial issue, and also the staffing to get the expert to come to your house and to do dialysis at your house. So end up home dialysis in Malaysia is just peritoneal dialysis, of which you need to have a tank of catheter, put in the water in your tummy. It's a dialysate, it's not a normal water. Okay, we call it dialysate. It's a special fluid in order to clear the solute and the fluid from the body. And of course, next is transplant. And all of us know that transplant is the best option of renal replacement therapy, but unfortunately, it's not that our patient doesn't want transplant, but they do not have suitable donor for transplant, or they are not fit for transplant. And finally, is palliative care. Is still an option because end of the day, what we want is our patient in a comfort, not in pain, and not in kind of suffering. Even though the patient opted for dialysis at the beginning, palliative care is still an option if they are not improving after the dialysis initiations.
Okay. Thank you very much, Dr. Maisarah. So you mentioned about transplant. So that nicely goes into our next kind of a speaker, Mr. Caldip. So Mr. Caldip, can you introduce yourself and what are you doing in UMNC?
Okay. Good morning. A very good morning, and thank you for inviting for the forum. Okay, my name is Kaldip Singh. I'm now 62 years old and been transplanted for the past 26 years.
So 26 years.
Yes.
So did you get transplant in UMMC itself?
Yes. Those days they call it the PPUM, Yes.
Oh, okay. It's still
in the year
PPUM now, but I
1994.
think it's an English or Malay kind of a translation.
Yes.
1994, there's already kind of a transplant in UMNC or PPUM.
Yes.
Can you tell me, how's the transplant at that time? Was it like, very hype, people want to get transplant, or is very kind of a, not so famous?
No, like those days, the waiting period was not long, I hardly waited only for hardly 3 months,
Oh, okay. So,
yeah, because
in your case, you got your kidney from a living donor or from a cadaveric, somebody who has died?
No. I got it from a living donor, That's my elder sister,
All right. Okay. And
Yes,
how is
yes.
she now?
Oh, she's doing very well. Both are doing very, very well, in fact.
All right. Okay. Was transplant, let's say 27 years ago, was it something known to patients like what it is now? Or do you think it wasn't so known at that time?
No, but at that time we had a consultation with the nephrologist. You see, he explained to us. You see, what is dialysis, what is transplant. So that's why I came to know about this transplantation. You see.
Because 1994, that's very early on. I have
Yes,
to say,
yes.
That's very good. And you managed. I remember you told me you managed to get a dialysis session, for a few months before the transplant. How do you compare the two, being in dialysis and being in transplant?
You see, of course, the doctor gave me an option. No, you only have like option like dialysis, and then one is peritoneal. One is CAPD and one is a transplant. But he told me the best will be the transplant. Like after transplant, your life will be back to normal, and all this kind of stuff,
Okay. And do you find that your life is back to normal after transplant, or what are the challenges, perhaps afterwards?
No, because I was on very short trial. I was doing dialysis for hardly 3 months. Then, like after my transplant, I don't feel like I'm a transplant patient, because you feel very normal, I do what normal people does, you see.
Such as?
Yes.
Such as what normal people do? I'm interested to know.
Oh, normal, like normal. Like if you go for jogging, we play badminton, like you work normally. You never think you're a transplant patient, you see.
Okay. I guess living for 27 years with a transplant, you tend to forget sometimes you have transplant.
Yeah. I already forgotten. In fact, I don't think I'm a transplant patient at all, actually.
All right. Okay. And the kidney still functioning okay now, right? After
very good. Yeah, very good. Functioning very well.
And to what extent can you push yourself now, even with the transplant? Can you say you're jogging and you play badminton? Tell me more about it.
No, like badminton is it's a very it's a very tiring and I play with normal people. Sometimes you play better than normal people. Like some of my friends, if you don't tell them you're a transplant patient, nobody knows that you are a patient.
I thought you were representing kind of something for your badminton.
Yeah. Because before my my kidneys failed, I was very regular playing badminton also. So after my transplant, I came to know about these games. They have biannually in different countries. So I came to know these games through this NKF. So ever since I've been participating from the year 1997 until the year 2018.
2018. So that was your last participation in the.
Last participation. Yeah.
Mr. Caldip, let's go back to, let's say, 1994, because at that time, I think, at least 5 years ago, there was overseas transplant was very famous. And I'm sure during your time, overseas transplant is still kind of it's illegal. What makes you want to do local transplant at that time? Because I'm sure the transplant program in Malaysia at that time was not, well established yet like what we have now.
No, because after, referring to this nephrologist, they gave me the option, the best with your family donor, you see.
Okay.
And then, of course, overseas transplant is, overall is illegal,
True.
And then, since my family came to know and, I had a discussion and this, that, they said, no, we'll do something, Then my elder brother and my elder sister, they went for this tissue typing and all this. So I was lucky that both of them matched perfectly, you see. So I never think of or dreaming of going any overseas transplant, you see, because I had my own family donor, you see.
Just reminder for the participants, if you have any question to Mr. Caldip or any of the panels, you can put it in the question and answer chat. So Mr. Caldip, I remember something. Was it difficult to kind of explain to your siblings about your kidney disease and the need to get transplant? Because I have a lot of patients who basically, they're a bit reluctant to let their family know because they don't.
No, usually these nephrologists, they will call the whole family, for discussion. They will explain, this is what I'm going through,
Okay.
So they was quite understanding,
That's a good tactic. Instead of putting the burden on the patient himself to kind of explain about the need for transplant. Yeah. Okay. So, Mr. Kaldip, there's a question. What medication does Mr. Kaldip take to prevent rejection after the transplant?
I'm on this 5 mg penicillin, cyclosporine, all the anti-rejection drugs, and then of course I'm on Caldip also because my potassium always on the high side,
Okay. And did they change the medicine all these years? I mean, for the past 27 years?
Yeah, ups and downs. It all depends. Sometimes actually, like this hospital is our second home. Like sometimes the creatinine goes up, then they do some biopsy, then with some changes of medication. Just follow the doctor orders, whatever they say. And
Okay.
in this UMMC, the doctors are perfect. They're one of the best came across.
Okay. All right. Thank you, Mr. Kaldip. Yes. Thank you, Mr. Kaldip. I just go back to Dr. Maisarah. Dr. Maisarah, are you still there?
Yes, I'm still here, of course. Okay. You can see my face.
I'm wondering, Mr. Caldip was saying a transplant back in 1994. What can you imagine? I mean, the difference between the transplant at that time and the transplant now. Is there any difference, or technology difference, or participation difference? Your answer.
Okay. Back in 1996, right, Mr. Caldip?
Yeah, no, 1994.
Okay. Yeah, well, back in 1994, it's a long period of time. As we know that survival of living kidney transplant for our country is about 15 years. Mr. Caldip has shown that it can last more than 15 years, which is very good. And now I know his kidney function is still very good and he's still happy with his kidney functions. So the difference in regards to perhaps start with the investigation, kind of the preparation for the transplant itself, because all days perhaps detecting donor-specific antibody, basically to identify whether you have antibody towards the donor, is not as good as the current moment. What we call it at the moment, we are doing Luminex single antigen big to detect donor-specific antibody. Those days, perhaps panel reactive antigens, or we just do a simple cross measures in order to get the patient transplanted. That's because of the technology is evolving, and we are in line with that. It's just that I guess for our country, we need to work hard in terms of our immunology services to make it available, easily available in our country, especially to monitor them after the transplantation. With this evolution of technology, we know that there is kind of low incidence of acute rejection or hyperacute rejection after the transplantations. Other than that, in regards to the immunosuppression, as you heard just now, Mr. Caldip said he's on cyclosporine back in 1994. Now, in terms of immunosuppressions, a majority of the patients will be on tacrolimus, other type of calcineurin inhibitor, as compared to cyclosporine. We believe that tacrolimus has less side effects in terms of kind of the gingival hyperplasia, in terms of hirsutism, those kind of side effects. And we believe that tacrolimus perhaps is kind of much stronger than cyclosporine, and in preventing rejections, and hopefully recent years with the transplantations, the outcome is much better as compared to old days. But yeah, Mr. Caldip has proved that despite all immunosuppressions, his kidney lasts for the past 6 years already. This is with regular monitoring. Yes, he need to come to the hospital whenever his kidney pick up, because we need to find the etiology why his kidney function increasing. And of course, sometimes the reason is very simple. It's just because of less water intake.
Okay. Dr. Maisarah, there's a few questions I think may be related directly to transplant. So, for example, how long is the waiting time for kidney transplant currently? And can the donor with a different blood group be a donor?
Okay, how long is the waiting time for kidney transplant currently? It totally depends on what type of transplant. If you are planning, if you have a donor, you are lucky to have a suitable donor, then you can come forward to major hospital, the main hospital that did living donation kidney transplant, like Hospital Kuala Lumpur, like ourselves, PPUM or UMMC, or Selayang Hospital. A private sector, you have Prince Court and other private sector as well. So it's totally depending on the hospital waiting time. In UMMC, generally I will say after you complete all the workup, because we really need to make sure the patient safe to undergo transplant. They are fit in terms of cardiovascular, they have a suitable donor. We need to make sure the risk of rejection is very low. All this workup at least take about 6 months. But of course, if you do this workup at different setting, which is in private sector, you make it faster. And after the workup completed, perhaps between 6 months to a year, you can get listed or you can have your transplant done. But unfortunately, for the deceased donation, it is a little bit we are a little bit far behind as compared to other developed country, because actually difficult for me to say the waiting time for the deceased donation, because it may takes about 10 years down the line, or more than 5 years, actually more than 10 years, especially when you are on dialysis already. So can a donor with different blood group be a donor? Yes, of course. But we will do some assessment first, because before we say you are eligible, because we really need to look at the antibody titer in between the donor and the recipient to the donor. So yes, the answer is yes. You can come forward and test for the NTA or NTB titer.
Okay.
Wow,
All right.
there are a lot of questions.
On transplant, it's okay. I think we'll go to Sheriza first. I don't want her to be waiting for a long time.
It's okay.
Dr. Sheriza, palliative care consultant. So we know from Dr. Maisarah just now, there are a few options when they reach end stage of kidney, and one of them is palliative care. I previously always associate palliative care with cancer. So what palliative care has got anything to do with the kidney patient?
Okay, Assalamualaikum and a very good morning to everyone. Firstly, I would like to thank the organizing committee, and again for Professor Wan Hafiz to kindly invite Palliative to be included in this World Kidney Day in conjunction with your World Kidney Day. So it's a very good question. So with the evolving palliative care that we are having in the country, the service of palliative care is evolving. So what happened is initially palliative care is only linked to patients with cancer diseases. However, at this point of time, we are also including end organ damaged patients, including end-stage renal failure disease, cardiovascular disease, even motor neuron disease or neurological diseases. So again, I would like to re-emphasize on the definition of palliative care itself. It's a specialized medical care provided by a team of specialists to improve the quality of life of patients with serious illnesses. So serious illnesses can be non-malignant cancer patients and also non-malignant patients and also cancer patients through the control of symptoms. Here we are talking about pain, breathlessness, and of course at the end of the day, reduce suffering to improve the quality of this patient's life. So I hope it answers your query about that.
So I imagine many diseases, not only cancers, would need palliative care help towards the end, technically speaking, right?
Definitely, everybody will need end of life care.
Okay.
Uh,
Can you die without palliative care?
of course, I mean, people can suddenly die. But the thing is, with the availability of palliative care and us as physicians knowing the disease trajectory, we are able to predict what is the likely disease trajectory for individual diseases. For instance, what our expectation in a cancer patient? What is our expectation of the disease process in a end organ damage? So with this prediction, this disease trajectory, we are able to predict how the patient will progress, what to expect, and with that, we can also, of course, control their symptoms, make sure that they understand where things are going. So there is more conversation about how to care and what to prepare. That would be the advantage of having palliative care at this point of time.
And based on experience, because Dr. Sheriza actually sitting in our clinic as well on Wednesday morning as part of the multidisciplinary team dealing with end-stage kidney disease. So are there many patients, or what makes they choose usually palliative care instead of dialysis? Because I think 40 years ago everybody wants dialysis. Now some people don't want dialysis.
Yes, so that's a very good question. So I want to highlight now that conservative care is an acceptable option of care for patients who have CKD approaching end-stage renal disease. So this may not be known prior to this, previous years, but now we know that this is an acceptable choice. So usually why patients need palliative care is that it may be decided by a nephrologist already in consultation with the patient. This may be due to the patient unable to have or undergo renal replacement therapy due to maybe severe or even poor underlying comorbidities, or even SS issues. Or the patient themselves have decided to be on conservative management after consultation with nephrologists due to personal reasons, or maybe even from personal previous experience of family members, even close friends. So I have had patients who, when we have started this clinic collaboration with the nephrology, in the nephro clinic every Wednesday. We have been doing this since 2019 March, and so far the number of patients that have been with me is about 140 patients. So
140
these are
patients.
patients who are choosing conservative for the past 2 years, and I would like to just highlight that this patient who have started with me in March 2019 are still alive and still doing well.
Are they being referred to early perhaps? That's why they're still kind of doing well?
So the ideal situation is that we want to have patients who choose the option of palliative care or conservative care of RRT to be referred early, especially in stage 3A or B. Why? Basically, we want to make sure that we can preserve the residual renal function, make sure that the progression of renal function doesn't progress too fast or too quickly, as what Prof. Maisarah did mention this earlier, that we want to control. And of course, we want to make sure that the patient and even the family members understand what they are expecting with kidney disease, what are the expected progression of symptoms or even disease, what would happen. With all these patients in palliative care, the most important thing is support for the patient from the family members. And of course, with them being referred early, we can discuss about their advanced care planning in the sense that what happens if at any point they become too ill or they become more symptomatic. Would they like to have care in the hospital or at home? If in the community, how would we continue care? These are very important aspect that we should discuss with patient. And again, at any point, patient may want to reconsider, should I go for dialysis? Because majority of the time when patients make this decision of whether they want to choose RRT or even conservative, they are asymptomatic. So when they say, oh, if I'm asymptomatic, why do I need to do dialysis? Why are the nephrologist discussing about dialysis? I'm fair, I'm well, I'm still walking, I'm still working. So the thing is, we have to communicate about what are the expectation that they want to look into as the disease progress, what are the disease symptoms, what to look out. And again, if at any point they feel that this is not their ultimate decision, there's still consultation, collaboration with myself and the nephrologist in the clinic to have this conversation again with the patient.
So, in your position or in your kind of opinion, it is still okay if patients was half-hearted palliative care and decide want to change back to dialysis. And that goes into, I think Dr. Khor Min was asking about similar things as well. You know, we find a lot of patients who initially decide not for dialysis reverses their decision when they become unwell and end up in ED. Is it lack of the communication, or is it they actually still have the options to choose?
Of course, definitely, this the decision of going into conservative palliative care for kidney disease is not final. It's something that they can still ultimately change. So this is very clear in my consultation when I first have my contact with the patient and the family. I would discuss about what our roles and aims of role of palliative care, symptom control, improve quality of life. Of course, I would also discuss why they choose conservative care. I have to be clear about why are the reasons they choose conservative care. Is it because of medical decision that has been discussed already by the nephrology, or is a personal reason? Or sometimes they don't even have reason. They say, oh, this may be the better option, less needle, less pricking. So I would then forward the question of what happens if you become more symptomatic, especially when you are breathless, when you have fluid overload, because that's when a lot of people feel very frightened. Because when they are having fluid overload, they feel they cannot breathe, they feel frightened. Yes, I want everything. So some are very clear that they don't want to do dialysis despite all the symptoms that may appear later on. But some will say, oh, maybe that I want. So again, if this is something that they will consider, I will just again have proper, communicate them again to examine the various options available for their kidney disease. Is it RRT or conservative? We have to talk about the benefit. Again, I would like to point out, I do not want my any patients to actually who would benefit from HD to start HD late, because again it increased mortality. So that's the reason palliative care, we are sitting ourselves in the renal clinic so that we can always refer to the nephrologist, discuss patient whether or not we can initiate dialysis at any point if they change their mind. And I think the nephrologists have been very supportive of this so far. So usually I just refer back to yourself and also the Prof. Maisarah.
I'm sure Maisarah would be happy to hear that. Okay, or Prof. Lim.
Yes, we're working together.
But were there many kind of people who changed their mind based on your experience?
In my experience of the past 2 years, I would say it's a handful. One was, I will just give an example. I had one patient whereby she's working in a healthcare professional but retired. However, she had no family members around. They were all overseas. So she was just maintaining her follow up. She was asymptomatic. However, as she became more symptomatic, more breathless, edematous, the children came back. So they then had a discussion with her and said, okay, now they will support her. So that's another option that she changed to HD, because the option of family supporting her, because initially she said if there's nobody to support her, the financial needs, all these things, there's nobody to bring her to HD. She feels that whatever life she has had is sufficient for her. So that's one. Another one that changed dialysis was he was also a retired government officer who loved to travel. However, he feels that he's around 80. So he had been traveling, and he traveled every month somewhere to overseas. So he don't want to be restricted by RRT itself. During that time, transplant was not an option for him also. But however, later on, when he had further discussion about pros and cons of RRT, then he opted for RRT himself, HD. So these are some of the scenarios where they change. However, there can be also family members who feel that, oh, I feel I want my parents to live longer, to have better, time with us. However, at the end of the day, the decision relies on the patient. So patient's autonomy is very important. That's the reason advanced care plan is being discussed with patient at my consult to know what happened. Because sometimes family members are not around, and suddenly when they become more symptomatic, family members come in and they are not aware what the patient's maybe preference of care are, what their wishes are. So here I would just emphasize on what the patient have discussed, and if they are agree and able to support, is okay. If not, of course, we will have further discussion with nephrology into whether this is appropriate change or appropriate support for patients to go HD or not.
Okay, thanks, Dr. Sheriza. So it seems to me that, we have discussed transplant and dialysis in between, and palliative care seems to be like, a bottom kind of option. And obviously that goes into what Prof. Lim Sukun has been asking. I have to ask Maisarah, because transplant has been geared up, has been hyped as the kind of a treatment for kidney patients, not getting transplant means that's it. What do you think, Dr. Maisarah?
Well, we are aware at our current situations at the moment, even though we think transplant is the best options of therapy, but it's not everybody has the privilege, which is they have a suitable donor, like I mentioned earlier. That's not the end of the world or end of the life. We do still have other modalities of renal replacement therapy. Yes, your kidney has failed. We have hemodialysis. I have a patient that's still on hemodialysis more than 10 years, or in fact some more than 20 years on hemodialysis, but the patient need to be comply with the restrictions, the food restrictions, the water restrictions. And on the other hand, we do still have peritoneal dialysis, of which that patients can do it at home. According to their time, they can adjust the time according to their situation to do peritoneal dialysis. As some of you might aware that peritoneal dialysis, we have two options of that. Technically, these options depends on the patient's status of the peritoneal membrane, which is either they do 4 times a day. But believe me, 4 times a day, it sounded hard, but once the patient start to doing it, they didn't find any problem in doing peritoneal dialysis or CAPD 4 times a day. Some, if the membrane status is not so good, they tend to develop fluid overloads. We offer for the APD or automated peritoneal dialysis, of which they just need to do it at night during the sleeping time. And sometimes we do consider, because some of the patients, they had difficulty to do daytime, but they are young patients, they still want to go to work. So in fact, we did ask if they are affordable for APD to do it at night during the sleep time and adjust according to their lifestyle. So there are other few other modalities that are available around. It's just that at the same time, patient need to comply with the restrictions, especially the potassium, the phosphate restrictions, and practice the healthy lifestyle as well. Because even though the kidney has failed, they are still having diabetes, they are still having hypertension, and those need to be managed. Because if that is not being managed properly, the diabetes, the hypertension can cause ischemic heart disease, and eventually they end up majority of them end up with cardiovascular mortality or die because of the cardiovascular event.
So it's not really end of life. I remember, no, okay.
No,
So
no, no, it's not. It's
because I
not.
remember only like 40 years ago, 50 years ago, uh, when dialysis is really scarce, people actually are, wanting dialysis. They have to be picked to do dialysis instead of
Yep.
dialysis being freely available like what we have now.
Yes.
So imagine things have changed a lot for the past 40, 50 years where, people are now talking about transplant to one extent and palliative care to another extent. So I think we are nearing our end. I'm not going to finish at 9. There are a few more questions. Um, uh, Perhaps I'll take Mr. Haris from vascular team to Sheriza. Which group of patients mainly opted for palliative care? Is there any like age group or certain?
So basically, usually the groups that I'm seeing is majority are more elderly, and then and also those who may have had family members who have undergone renal replacement therapy and had poor outcome. These are mainly the groups that I'm seeing. And at the same time, there are those who feel, especially for the elderly, they feel that, oh, they had enough good life. They think time, whatever time is left is should be for them to enjoy and just be with the family members and not be stuck to the machine. I'm so sorry to the nephrologist. Some of the perception of the patients would be being stuck or being placed in a HD center to the machine every 3 times a week is something that they do not accept as a quality of life. These are some of the reasons that I've seen. I would also like to just answer the questions. Do palliative care means giving up? So the thing is, of course, the misconception about palliative care is just waiting for time. Time is going to be short when we start palliative care. However, when I start a consultation with patient and family again, I will ask what do they understand about palliative care. We know roughly what they heard or they don't know anything. From there, I will just explain what our role, intent of palliative care, what are the expected follow-up that we'll be doing, what would be the expectation of the care. So some would feel that this is something that is in line with the preference of the patient, because family members may say, oh, they know what the family members, the father or the mother or even the siblings want for their care or their goals of care. If it's in line, they agree. That's when we can work as a team of patient with myself and the nephrology to make sure the care is appropriate for this patient. And again, patients are still I appreciate the nephrologist referring them early, because when we refer early, there's good rapport. We can collaborate. We can understand where the patient's goal or expectations are, and we can provide what they need. If we are referred to by the team late, and when they are at the end of life, it's very difficult to manage the goals of care of individual patients.
All right. Okay. So I think in the final round, I will ask each panel probably to summarize what their hope for 1 minute each. Mr. Kaldip, are you still there? What do you see
Yeah.
yourself? How do you see yourself? I think, as how to live well with the transplant or continue to live well with transplant. 1 minute, Mr. Kaldip.
Actually, the most important, you follow the doctor orders, manage your diet, keep yourself fit by doing some sort of exercise. Doesn't mean you're walking, any sort of exercise. And most important, take your medication on time.
And that's how it has helped you for the past 26 years.
Yes, for the past 26 years. But I see the most important, what I see is sports.
What do you see? What?
The most important, you must be active in sports. The way I see it,
Okay. Yeah, I think I should as well.
And that's really keep you healthy. The movement is there. The way I see it, like my personal view, is it?
Okay.
Yes.
All right. Okay. Dr. Sheriza, 1 minute. Your hope and summary, how to live well even in a palliative kind of a setting.
So number one, of course, I would like to highlight that palliative is an option for CKD and stage renal failure. However, it has to be decided with proper consultation with nephrologists. If it's appropriate, of course, I will support. If it's an inappropriate decision, then of course, nephrology have to have more conversation and make sure patients are aware of the roles and goals of RRT versus conservative. Our population is aging. There are patients who would like to have palliative care. So it's an open option. It's a collaboration. We work hand in hand for the better sake of our patients' care. That's my thoughts. Yes.
Great summary, Dr. Sheriza. So, Dr. Maisarah, you as a final member, 1 minute to summarize our discussion. You're muted, Mai.
Okay, so I would like to share this. Yes, of course, everyone hope they can get kidney transplant, and all these pictures, some of them, and all these patients are consented for transplant, and they are happy after transplant. Their normal life, like what Mr. Kaldip has said, these patients basically from 1 kids to 2 kids, and now going to have a 3rd kids. And these patients, even though before the transplant, she's still able to go travel overseas. This picture basically when she's on CAPD, and she able to accommodate herself how to travel to attend the son graduations, and this after the transplant. And you can see a lot of others, and this is the donor. You see the donor with a smiling face, even though he need to donate his kidney to his brother, but of course because of the love, so he's still donating with a smiling face. So of course, transplant is still the best options, but it's not everybody have this opportunity for transplant. Not giving up, you still can live happily. Okay, like our team for WKD this year, living well with kidney disease, because even though you have kidney disease, you end up with dialysis, but we have a lot more patients, like you have seen in our statistics. They are on hemodialysis, they are on peritoneal dialysis, and they are still doing great at the moment. They are still going to work, they still do the normal life. And apart from that, before you get the kidney disease, make sure you know how to prevent it and detect it earlier by doing early detections. Practice healthy lifestyle, drinking a lot of water, no salt, prevent diabetes especially. And of course, if you are high risk group, especially the age, the family history, you have diabetes, please do a regular screening of your kidney functions, because I want to show just this, because the kidney disease is very silent. Some of the patient might not know they have a kidney disease, but they end up with end-stage kidney disease. If you're able to detect this kidney problem earlier, at least we can give certain treatment according to the etiology of the disease. Yep. Thank you, Hafiz.
All right. Okay. So I think that will be it for our WKD today. Tomorrow we have half a day kind of lectures for those who have registered. So thank you very much for panels, for your great points that have been discussed. So I hope all the participants have some glimpse of we can still live with kidney disease despite whatever options that we have, either CKD, transplant, even palliative care. We can still live and live a beneficial life in whichever option that we choose. With that, I would like to thank the organizer, and we'll see you again next week with another topic. Thank you very much.
Thank you. Bye. Assalamualaikum.
Thank you.
Thank you. Thank you.